we're going to hand over now to the one and only Mandy Peach. Mandy is just finishing up her fellowship in point-of-care ultrasound here in St. John, and she's also one of our staff physicians here. And so Mandy's going to give us a focused PoCUS talk about ocular ultrasound. Thanks, Mandy.
Everybody can see my slides?
Yes.
Yeah, okay, sounds good. So I decided to do an ocular PoCUS just because I think it's a really useful application that can really help expedite patient care in certain populations. And it's something that's really easy to do. So I thought it'd be a good review today, and hopefully some people can incorporate it into practice. So pretty common case, right? You have a middle-aged person, comes in with sudden onset flashers, floaters in an eye, progressively worse vision, and often they'll have a history of previous diabetic issues or vision issues. The differential is really broad, right? It can include vitreous detachment, retinal detachment, vein or artery inclusions, and the list goes on and on. So initially, certainly, you're going to reach for your ophthalmoscope to do a fundoscopy exam. So certainly this can take some time. You may have to dilate the patient's eye, and it's not a particularly straightforward skill to do. I don't know about most people, but certainly I don't feel terribly confident sometimes in my fundoscopy skills. So I think reaching for an ultrasound probe can be really helpful in the right patient population. So in terms of indications for ocular PoCUS, certainly loss of vision is one of the more helpful ones. Someone with eye pain in the setting of an ocular trauma or potentially an intraocular foreign body can be helpful. And lastly, there's some evidence showing that it can be helpful in estimating intracranial pressure elevation in certain population. So the eye really is perfectly meant for PoCUS, right? It's very, very superficial. It's this little tiny bag of fluid that's going to transmit those ultrasound waves so very well. So it really is kind of the perfect structure to utilize. It's relatively easy to do, even with very minimal training. So there was one study that looked at training emerged docs with a 30-minute training session, and they were able to pick up retinal detachment with a really great specificity and sensitivity. So with some minimal training, it's quite easy to do. And time-wise, it's very, very quick as well. I think in a similar kind of study, they were able to pick up on retinal detachment in less than 60 seconds, right? So really quick to do, and certainly I think we can get through that faster than doing a fundoscopy exam. So definitely a good adjunct to your ocular exam. So you have to know the normal eye anatomy. So certainly here on the left, right, we have the vitreous body, which is going to look anechoic or black on ultrasound. Up here, you're going to have the lens, which is going to have this hyperechoic or bright outline. You have your iris coming across here, and then this is going to be the anterior chamber of the eye with the cornea over on top. So where we want to pay attention is certainly the posterior aspect of the eye. So the retina is going to be this layer that comes across the back. You can't see it on ultrasound, but the choroid layer is going to be behind that, and that's going to be the vascular supply for the retina. And then you want to be able to identify the optic nerve sheath. So this is going to be contiguous with the retina. So it's going to appear as this hypoechoic or darker structure that's going posterior to the globe. So this is what we expect to see on a normal ocular PoCUS. So for the scan itself, you want to use a high frequency linear transducer. Again, it's a very superficial structure and you want to get good detail. When you actually choose your exam under the ultrasound program, you want to choose ophthalmoscope exam because that will give you presets that want to minimize the amount of potential thermal radiation through ultrasound. So you want to, you can probably hear my kid screaming upstairs, I apologize. So you want to have the patient lying flat in those positions. So there's two options. You could do a tegaderm over the eye with lots of ultrasound gel. I typically forego the tegaderm and you could use sterile jelly, again, lots on the eye if the patient's able to follow commands. And then you want to make sure that the probe is sterilized as well in that case. Ocular kinetic exam, so getting them to look left and right, looking up and down while you're sweeping through in both a transverse, so marker to the right, or longitudinal sagittal plane, marker towards the head is going to be really important. When you're actually doing this as well, it's important that you want to like rest your hand either on the bridge of the nose or on the side of the face, depending on the eye that you're scanning, because you don't want to put too much pressure on that eye as well. So retinal detachment is a big one that we look for. So again, if we remember, our retina is going to be at the posterior aspect of the eye that we look for. So if you have retinal tears, whether it's related to trauma or spontaneous with age, once you get a tear, you can get vitreous body kind of filling in that space and eventually can lift up the retina further from the choroid. So because of this, it loses its blood supply and it can have irreversible vision loss. So that's something we want to prevent. So if we look at a still here for retinal detachment, so right away we see your anechoic globe. And right in the middle of this vitreous, we're seeing this abnormal structure. So as you can see, it's a thick, kind of hyperechoic bright band or membrane. And that's concerning right off the hop for retinal detachment. With the retina, this membrane is actually going to be anchored to the optic nerve head. So you have to see your optic nerve sheath in your field of view to be able to see if it's tethered. So in this view, you can see again that hypoechoic dark optic nerve sheath. And as you can see here, it's going to be tethered down. Because it's tethered, when a patient looks left to right, you're going to see movement. It's going to undulate almost like a snake. But once they stop moving their eye, the retina membrane will stop moving as well because it's tethered down. So those are really important things that helps distinguish what a retinal detachment will look like. So here's a couple of videos. So on the left, again, even with a low gain setting, you can see this really bright hyperechoic membrane here. And once the patient moves their eye, you see it undulates a little bit like a snake there. And then at the beginning of the video here, the optic sheath is around this area, and you can see it looks to be tethered here at the start of the video. We can also have another situation where you can actually have the tethering at the optic sheath, and you get both on the right and the left area. The retina kind of comes up and it has this V shape, which we see here. So here's the optic sheath coming back, and then you have the retinal attachment here. So that's what we expect to see. When you see it, it's pretty darn obvious. So how good are we at diagnosing these? So this was a prospective multi-center study that was done. Any adult patients who presented with flashers, floaters, blurry vision. So a really good story for retinal attachment were included in the study. So PoCUS was done by emergency doctors who had various training levels. So these weren't experts or fellows. It could be anybody who had training in ultrasound. This was compared to when they saw an ophthalmologist who was a diagnosed with retinal detachment. That was considered the gold standard. So as you can see here, the values are pretty good, right? It's a good sensitivity at 96%. Specificity is pretty good at 88% as well. But when you actually see it, right, it's so obvious that it's a pretty helpful test. If you see a completely normal globe, you maximize your gain and it still looks normal. And the sensitivity here is pretty good for confidently saying that there isn't a retinal attachment. So posterior vitreous attachment is something else you can see that looks similar to a retinal attachment. So if we look here again, we have our anechoic globe, and here we do see another structure that's hyperechoic. It does look thinner than the retina itself, so it looks like a thinner membrane. In order to see this, you really have to maximize your gain. So oftentimes to see retinal attachments, you plunk on the probe and as often you can see it without, kind of changing your settings. But with a posterior vitreous attachment, because it is thinner, you really want to kind of jack up your gain, and often you can see abnormalities that you might miss otherwise. So with a vitreous attachment, it's not tethered to the optic nerve. So at the level of the optic nerve sheath, you're not going to see anything tethered there. And you can also look at, in this particular video, it goes all the way across the globe. So there's nothing tethered to the posterior aspect of the eye. Because it's not tethered for your oculokinetic exam, when you have people looking left to right, even though when they stop their eye, you're still going to see movement. So in this video here, we see movement, they stop, but we still see a little bit of undulating after the fact. And so that's another thing that can help differentiate between a retinal attachment and a posterior vitreous attachment. So again, from that same study, they also looked at vitreous attachment. So the sensitivity certainly lower. And again, if you're not maximizing your gain, you could potentially miss out on this diagnosis, but the specificity, again, quite good when you see it, you see it. So vitreous hemorrhage is something else you can see. So depending on the timing of presentation, so if people present really early, the blood may not be liquefied yet, so it's going to look kind of darker gray, so not as hyperechoic, and it's going to layer out with gravity if the patient's not looking left to right. The longer the time, then this clot has the ability to form, so it's thrombus, so it's going to look brighter like this one. So as you can see here, right, you should see a nice anechoic globe. This is not normal. And as the patient is looking left to right, you're seeing kind of this swirling, almost like I think of it like a washing machine. You will miss this if you don't increase your gain, especially if people present pretty early because the blood haven't had a chance to form a thrombus yet, so it's not going to be as bright. So again, varying depending on when they present, but you really want to utilize your gain. You can see vitreous hemorrhage with a posterior vitreous attachment. You can see with a retinal attachment. You can see in trauma. So again, looking for that washing machine sign. So from that same study, the sensitivity 81, specificity 82 as well. So again, not perfect, but pretty good, and a good adjunct to your clinical exam for a patient with visual changes. So it's already been established that measuring the optic sheath nerve diameter has been associated or correlates with increased intracranial pressure. So the optic nerve sheath itself is continuous with the subarachnoid space. So you're going to have CSF that flows throughout. So the eye is great in that it's actually like an external part of the CNS system that we can assess and measure. So the really important thing in this view, so this is a still, is that you want to be able to scan through until you identify your optic sheath, which again, that hypoechoic dark area posterior to the globe. So in order to accurately measure this, you want to be at the right place. So you're going to put your calipers on the posterior globe and measure back 3 millimeters. And this is going to tell you where you're going to measure your optic nerve sheath in a horizontal plane. So that's the first set of calipers here. And then you're going to measure along that horizontally. So normal is going to be less than 5 millimeters, and anything greater than 5 millimeters, and you can see in this particular patient it was greater than 5. That's going to be concerning for increased intracranial pressure. So in the study, this is actually a systematic review that was done of 12 different studies. They did include a variety of patients. So they used adult patients where the cutoff was greater than 5 millimeters. If pediatric patients from the age of 1 to 17, they used 4.5, and then under the age of 1, they used 4. So here, as you can see, sensitivity, specificity was quite good as well. And then in terms of the likelihood ratios, so if you have a patient that you highly suspect has an elevated intracranial pressure, it could be a really helpful test. Or if you have somebody you have a low suspicion of and then it's negative as well, it can be quite a helpful test. So some other findings that you might see on PoCUS, one could be a lens dislocation. So the lens should be at the anterior part of the globe, but as you can see here, we have this bright hyperechoic structure that's right in the vitreous body, and that's certainly abnormal. As terms of a foreign body, so a lot of foreign bodies, especially metal, we're going to be quite hyperechoic and quite bright. So something that's abnormal within that globe. You can actually put color Doppler on and it creates this artifact. So it actually looks like a twinkling sign. You can use this to see this in kind of stones as well, or anything that's really calcified in other parts of the body. But you see these bright flashes of blue and red. So it kind of creates a twinkling. And then lastly, globe rupture. So if you truly suspect a globe rupture on clinical exam, it's a contraindication to use PoCUS. But if you really know clinically you're not quite sure, you still can go ahead and use PoCUS. My recommendation would be to just put a ton of gel. So again, because the gel is such a great conductor, as well as the vitreous itself, you don't have to put a lot of pressure. But if you do see signs of a globe rupture, that's helpful clinically, but then you take that probe right off because you don't want to push out any vitreous. So here, we looked at earlier vitreous hemorrhage, which is quite obvious there. But what you're going to see with a globe rupture is that because they've lost some of the vitreous, it's not going to be a perfect circle. So you're going to see some irregularity. It may even appear oval shape. And the anterior chamber is going to be squished down as opposed to nice and opened here. And then in this case, like I said, we see the hemorrhage. So if you see those, you want to take your probe off right away or not apply too much pressure. But again, that will definitely confirm a globe rupture. So some other indications, not well established, but if we want to have a look at the blood flow too through the optic sheath, right? So branch off the ophthalmic vessel. If there's an occlusion there, so in an artery occlusion, there was some study where they actually saw this bright hyperechoic thrombus. So if you look back posterior to the globe where the optic nerve sheath is, you see this bright area. Again, no kind of accuracy study, but one paper did quote about 31% of the patients who had a retinal artery occlusion had signs of that bright hyperechoic thrombus. You can also put flow on, which is helpful in lots of situations for PoCUS. So back here, you really would expect to see 2 flow. So here you see flow there, but you should expect to see both an artery and a vein, so blood flow in kind of both directions, and we really only see 1. So you should expect to see 2 in that case. Something else you can do to help as well, if you put pulse wave Doppler over it, with an artery, you should expect to see kind of a peak and wave kind of correlating with the pulsing. whereas in the vein, you expect to see kind of a flatter line. So that can kind of help differentiate which is potentially occluded, but I thought that was interesting. So in summary, ocular PoCUS, even with minimal training, it's quite easy to perform. Certainly once you see that pathology there, it can help expedite your care. And as emergency doctors, we're pretty darn good at identifying, especially retinal detachment. But if we increase our gain and kind of maximize our likelihood of finding up on pathology, we can see vitreous detachment and hemorrhage as well. And that's the end.